After seeing those subretinal TPA, now next step is if you encounter the bigger problems. So I think this was one case I wanted to share with everyone. This was in fact our first case which when we restarted surgery after COVID lockdown. So she was a lady who had cataract and posted for cataract, and when cataract team realized that there is no glow, there is dense vitreous hemorrhage and probably retinal detachment or massive subretinal hemorrhage. So we took her for combined surgery, removed the cataract, and after removing this dense organized vitreous hemorrhage, and here you can see, despite the fact that she was having massive subretinal hemorrhage, her macula was spared. And at this point, I was thinking I'm not going to do anything for this blood. I'll just do fluid air exchange and leave it. But when I was doing fluid air exchange, this whole thing ballooned like anything, and it was threatening to involve macula. So I tried draining it transclerally, but it didn't drain. Just like I thought, just like we drain suprachoroidal hemorrhage, will drain subretinal bleed. It didn't. So I decided to leave it alone and just with gas, and she recovered very well, 612 vision, and then we were planning to do an angiography to find out the reason for the bleed, but she returns with drop in vision, and she already had a history of macular hole surgery being done in her fellow eye. So she came with a macular hole in this eye also, and again the hemorrhage has already started organizing, and we planned a resurgery for her, and again the conventional peeling, and then we have used ILM flap. And even at that point there was significant amount of blood lying all around arcades and in periphery, and again it was tempting that should we do something for blood, but I again decided to leave it alone. And this is post-operative picture. The hole closed very well with the flap. This time she regained only 6/18. And but this is very interesting. When you do angiography or autofluorescence, you can actually assess the damage done by subretinal blood, and that is a good way of assessing long-term outcomes in these cases. So you can see, despite having massive subretinal hemorrhage, but macula was not affected. She could maintain good visual acuity, and nothing was required to be done. So that's why I thought I should share this. And we were suspecting malignancy also. We did angiographies, PET scanning, but it turned out to be some inflammatory or hemangioma-like lesion, which we lasered nasally, and she settled down nicely. So this was one case, and then this another case, again patient with proliferative diabetic retinopathy, where we have done VR, removed silicone oil. He was doing well with 612, 6/9 vision, despite having very pale disc. And then this guy deteriorated. He was on dialysis, and he developed this sudden loss of vision and this submacular hemorrhage. And now I knew that this guy was on wheelchair, and he's not going to maintain any kind of position. Prone positioning was almost impossible. So again, we just decided we'll inject subretinal TPA and maybe some air and leave him alone. Let's see what happens. And again, the point what Dr. Reddy was highlighting, that if you are not able to get in, don't try that point again and again, because you will end up creating a larger retinotomy. So go to another area, and this blanching happening tells you that you are still not in subretinal space. Yes, and then once you are in the subretinal space, you can see I have injected TPA followed by air. And again, this was this fundus picture 4 weeks after surgery, significant displacement of blood, and we have just injected air in this patient. So again, doing very well with this minimalistic approach. Another patient, he was 90-year-old, having dementia and I think COP, and he had a massive subretinal hemorrhage, almost hemorrhagic RD on ultrasound, and picture was like this. There was almost total detachment. I was trying to induce PVD, and at this point he got very restless and uncooperative. So again, whatever we have, I was planning the extensive surgery like Dr. Shubhendu is doing it very regularly. So, but in this case, because he was so restless and non-cooperative, I realized that I should not be doing extensive. I'll just do whatever minimum can be done. Created retinotomies in 4 different quadrants, and injected PFO, And you can see everything is so shaky because my assistant, one of the assistant was holding his head, two guys were holding his legs, and somehow we could drain maximum blood with just these four retinotomies. And you will see in the end there was only inferior few mounds left. Remaining blood was nicely drained. And this was, and we injected silicone oil for obvious reasons. And this was his outcome at 6 weeks. He could regain 6/12 vision. Another patient having this submacular hemorrhage and some breakthrough hemorrhage also. We again, as a rule, tried intravitreal gas, but it didn't work much. So, and this is the point I was highlighting in the first talk, that if you have to plan a subsequent intervention, your first aid intravitreal gas doesn't interfere with that. Now, this is again, you see, patient has hemorrhagic PED here, and I'm going just at the edge of PED, and my interest is to displace this central blood, and you can see the bleb. And now I'm going to make another bleb in this area where I could see organized blood. And that's it. And here I was not keen to inject subretinal air because I was not sure whether it will be retained, and the retina was so thinned out. So I was not very keen to create bigger retinotomies. And again, this patient does very well. 2 weeks after surgery and 6 weeks, he regained his pre-hemorrhage vision of 6/60. And this was again a one-eyed patient, so I think it was quite reassuring for him. So to conclude, I think in general, when we are managing these even larger, bigger subretinal hemorrhages, our main target is to get rid of blood from macula and the most healthy retina with whatever patient is having at that point of time. And of course, like I highlighted, blood is going to shift temporally and inferiorly, so one has to plan accordingly. And again, I've already said this, that heme, just underlying fovea and the height of blood at fovea will help us decide our ultimate approach for these cases. Right. Thank you.